Welcome back, everyone. We're heading into session 4, real-world implementation, and we will hear from Dr. Jeremey Peterson. Dr. Peterson is an assistant professor of neurosurgery at the University of Kansas, specializing in cerebral vascular and endovascular neurosurgery. He treats aneurysms, AVMs, stroke, and vascular tumors, and conducts research on vascular malformations and interventional stroke care. Dr. Peterson, welcome, and I will turn it over to you.
All right, let's see if we can share this. Waiting for approval to share. There we go. All right. All right. So I'll be kind of talking about some of our experience at KU today. And a lot of this is really because we're kind of getting back into the ICH game. We were very active in Misty when I was a resident there, and then I did some Apollo cases where I did fellowship. But then when we came back, we weren't in the Enrich trial or anything, and so now we're kind of getting back into it. And we really took a look at our institution level of how we were doing this and kind of creating this infrastructure with all these changes. And Chaley, Jennifer, the rest of our team, everybody else that helped, put together some of these data, the slides that we have today, and kind of be talking about our, what we call the acute ICH response team, kind of similar to our acute stroke response team. So that's kind of my relations there, but not pertinent to this talk. So general overview, you've seen this with the other talks. Ischemic stroke, much larger population base. There's much more comprehensive guidelines. This process for the last 15 to 20 years has been getting standardized due to the kind of positive trials that we had. This kind of took off, and with reason, this is a more common presentation to us. Hemorrhagic stroke is kind of lagged behind slightly from that. Number one, from the decreased numbers of it, but also the higher morbidity, mortality, which the other speakers have kind of addressed. There's definitely more variable treatment approaches in that avenue and less standardization. And so from a standpoint of our stroke center, this is kind of a look at our numbers, I think, over the last year and a half or so. So quite a few primary stroke activations, single neuro ICU, 2 progressive floors, and then obviously 24/7 vascular neurology support for this, as well as our neurocritical care, radiology, intervention, neurosurgery, and anesthesia for our acute stroke patients. And so when we look at the numbers for us, we actually, outside of the kind of averages that you see kind of worldwide, nationally for this, our disease at our institution is a little bit more skewed with a higher percentage of ICH and subarachnoid patients just due to our transfer settings and our patient populations that come to us. And so when we broke this down, we really wanted to look at, well, what have we been doing the last 20 years so well for acute stroke response? And how do we somewhat mirror that for hemorrhagic response, despite the inherent differences between the two disease process? And so we were kind of looking at, our acute stroke response. We've got a very good protocol of there's one number to call, the team's activated. We've got all of our teams set up to respond quickly. And then so we've standardized this, and with all these core members that we use, we're able to implement these evidence-based practices and make these quick changes when new science and technology is coming out to advance our care a little bit faster in this area of ischemic stroke. And so first step, we kind of have to look at some of our own house cleaning and baseline data that we have on ourselves. And we found out we haven't been tracking this as well as we have for ischemic stroke, and so kind of coordinating that. But over the last year and a half, this is kind of a little comparison of what some of our ICH numbers look like. I think this was through August of 2025. And so you can see quite a number of our patients are actually transfer patients, but we're kind of seeing an uptick in our kind of ICH patients that present to our emergency room or are in-house. Our subarachnoid transfers and patients, that's been fairly stable, which was shown in other presentations. But other areas we're kind of starting to look at is like our anticoagulation reversal. We've kind of seen an uptick in at least our reversal rates that we've had for eligible candidates and stuff. And so until we know these raw numbers and where we're sitting at now, there's not really a good way for us to improve. And so some of these general observations as we were putting teams together of like, where can we really make our biggest improvements early? One of the big ones was transfer time delays and not really having a feedback pathway for our ICH patients like we do for our ischemic patients, of what things can be better with that certain facility when we're doing a transfer. How can we communicate that back to them better? We saw significant delays in, blood pressure management and even in-house, as well as for our transfers of affecting some of the stabilization for these patients. And then for our acute stroke patients, our saying's always, we've always got a bed, send them, because we need to get their vessels opened up or get them cared for in a rapid sequence. This was different for our ICH patients where previous trials, even Misty that we're in, you had up to 72 hours. There wasn't this time-based, get them here as fast as you can, let's get them treated. And so we really had to transition that for that pathology that our transfer center would say, okay, we've got a ghost bed. We will get them to our facility, and then we will adjust things as they're transferring. And then just documentation gaps in general for things like anticoagulation reversal, when were blood pressure medicines given, and just having a conduit that's easier for our teams, whether it's in the ED or the transfer center, to capture this data so that we can actually start tracking it. And so why did we actually really get involved in kind of adjusting or kind of revamping our ICH pathway? The big internal drivers were that we were finding there were some inconsistent workflows across the departments, because before, depending on who took the call or who was seeing the patient in the ED or who they called for care of the patient, it could be the stroke neurology team if they're doing a acute stroke evaluation, or it could be the neurosurgery team depending on when the imaging was done, or it could be the neuro ICU team depending on who they were calling for a transfer. So we kind of had these three departments managing the same things. Well, then that can create this variability for these ICH patients. And so we found if we integrated all those groups and came up with a single pathway, that would potentially help improve the process. External driving factors, obviously, like the talk today, the AHAs have been much more proactive over the last recent years with their ICH protocols and kind of pathways to improve the care for these patients. There's obviously been this growing national focus with the positivity of the Enrich trial and looking at these ICH outcomes. And so that's kind of guided some of that from an external reason. Quality wise, obviously for Joint Commission and the Get With the Guidelines benchmarking, these have started to include ICH components, which we want to make sure that we're staying up to par with what we're doing on our ischemic side, now that these metrics and tracking of hemorrhagic outcomes and the process of getting to those outcomes is becoming more important. And then our overall vision for our patients is trying to improve the quality of life and the morbidity and mortality for each of these ICH patients, similar to what we've been able to do for ischemic patients. Despite the fact that we know the morbidity, mortality, and the disease process is entirely different from the ischemic patients, we wanted to at least try to use every bit of knowledge we've collected from that pathology to see if we can help with the ICH world. And like I said, another driving factor for us was being, involved in one of the ICH mentor sites for the HA. But I mean, this is something where many institutions, over 300 and probably many more now, are now including the ICH Get With the Guidelines data in their registries and databases. And so this was just trying to contribute, nationally with everybody else as far as what we're doing. So where did we start? Really, our first steps were forming this interdisciplinary ICH committee. So a lot of us getting together that had interest in this, with representation from all the different facets within our hospital system, they could look at this. And from that group, we kind of created these 4 subcommittees: the air activation team, which is kind of our acute ICH response team. That's really focusing and concentrating on the things that we can improve and do better at our own institution. It's usually probably better to get your own house in order before you try telling your transferring facilities or other people how to do things. And so that was really important to us to make sure we are doing the things we need to do and that we can prove that we can implement those before we start, just getting that out to other institutions. The other part is looking at our transfer protocol, which is important to us as an institution because that is where a lot of our ICH patients come from, is really transferring from other facilities. And so once we have a groundwork, we can take that transfer protocol and review that and optimize our transfer of the patient to us. But not only that, our tracking of the information of how we've implemented things and how can we help other institutions implement that, or where we've got a continuity of care between the facilities to optimize their transfer to us, but also optimize their rehab and recovery after all of this back to their community and closer to home, which is important for patients. Obviously, we need a group looking at all these clinical practice guidelines that come out with new research studies that were highlighted in the other talks. These things can rapidly change the information that we want to update to not just our guideline at our hospital, but we have to make sure we're following the same guidelines everybody else is, so our data is applicable to other facilities. And then number one, this information age of how do we find better ways with our data and informatics teams of collecting these metrics and tracking them and getting more of a real-time look at how are we doing this month versus last month. What happens if we have a complicated case that didn't fit within all of our diagrams? How do we collect that data quickly so that we can review that case like we do for our ischemic stroke patients of, oh, here's a problem that we found within the system because of one case. And so unless you collect that data or have easy ways to get it, it just won't go anywhere. And so here's kind of an overview of the stakeholders that we found at our hospital when we started really putting this group together. And so our data and informatics team, the lab, from a standpoint of how do we optimize our point of care testing and get the most accurate and quickest results for patients from a laboratory setting. Obviously, our stroke program and all of our kind of admin team that have been doing this for ischemic stroke. Our ED, as far as how do we communicate with them and get the patients that do present to us through this protocol and optimize all of their care. Radiology, from an imaging and reporting standpoint, how do we make it easier for our radiologists to contact the people that they need to initiate an ICH protocol? And then obviously our critical care, neurosurgery, and neurology teams all working together, because these are kind of the main teams that are going to be seeing these patients or that clinically had contact with these patients. And then leveraging our pharmacy for our reversal agents and making sure we have the best medications and are up to date on the newest reversals. Our probably biggest thing was getting our ASRT, our acute stroke nursing team involved, because they are kind of that point of care. They're that person that are going to be seeing a lot of these patients initially, and really just dovetailing that to our ischemic thing, with also taking in mind what kind of increased work that provides to that team, and do we have other backups and situations where they're not getting pulled in too many directions. And so kind of our core directives, the first 2 were really kind of about the patient's initial evaluation and shortening the time for our transfers of when do we hear about it, when do they get there, and how fast can we get them here. So our door in, door out time, similar to stroke. We wanted to shorten the arrival time of the patients from the time of their diagnosis to our ICU, whether that's a transfer or an in-house patient. The 3 and 4 are kind of overall goal of decreasing that morbidity and mortality for ICH patients, which is much worse than for ischemic patients. But how do we standardize our care process so that we know when we are implementing something, it is truly affecting morbidity or mortality? So we know whether that's an avenue to pursue, or do we need to look into another area to improve those metrics? And then 5 and 6 is really more optimizing our own team and more of a feedback process of having these meetings or outlets for our interdisciplinary teams to communicate the changes that they're seeing or things that come up, and then ensure that what we are implementing, we are being compliant with, and that those are concordant with the clinical guidelines, and making sure that all of us are kind of held accountable for our part of it, and that we review that and we can come back and look at it together. So some of our goals in action, obviously, our arrival time to treatment time, we wanted that to decrease. At this point, we're just kind of tracking that. But for ICU admissions, for all the patients, and when they get there to the hospital and then arrival to the unit, we want that under 30 minutes. Our blood pressure control, we want that initiated within 10 minutes. And that doesn't mean tank the patient, because like you heard before, we don't want this variability, but at least having initiated that blood pressure control and working on that as soon as we can. And then obviously our reversal for patients that qualify less than 30 minutes. And then really continuing this continuous data collection and feedback loops for every time we have a patient that comes through. So we're not just reviewing this every quarter or every year, where we're actually using the data as it's coming in to help guide us. And so some of these specific time goals that we use and other institutions likely use are our time from identification of an ICH and activation. So this had to do with our radiology team of, all right, once a scan shows an ICH, getting them a quick and rapid way to contact the team that they need to in order to see this. And then our acute stroke response nurse getting, to the patient within 5 minutes, similar to what we do for ischemic strokes. Initiation of that blood pressure control, making sure our labs are sent in a timely fashion, and then obviously our reversal initiation and time to arriving to our ICU for kind of more definitive care. So this has been implemented a few months now. We've finally got everything put in order and gone live. And so our activation types is part of the data that we're still collecting. As we can see here, our acute stroke response still is kind of our largest category of patients, where we already have our acute stroke team there, because the way these patients present, they can be very similar between ischemic or hemorrhagic, right? That's why you have to get a head CT on every ischemic stroke patient, because it could be a hemorrhage. So what we found is we already had the team there. They were already doing it for a majority of these. And so instead of saying, oh, well, it's a hemorrhage, call neurosurgery or whatever, we just continue the pathway of care, and that hopefully will help decrease time for all of these. And then neurosurgery, we can kind of come in the background, but this is all happening ahead of time. And so when we've looked at our data, small data set, you can't really glean any real scientific value from this, besides the fact that at least what we are tracking and looking at does seem to be objectively making some difference. But our kind of read time from the scan to the time of arrival to our ICU, we had 19 patients that we looked at before we implemented and 25 after, but at least our median and kind of average times to getting into an ICU bed has seemed to significantly decrease. Our blood pressure management, if you look at our median times, they've, kind of gone half. If you do averages, it's significantly down, but this is where small data, you can't make a lot of judgment from this, but at least it's trending towards making a difference. One interesting thing we found is when we looked at a few patients that were candidates for reversal, actually our reversal times went up. So we really had to dig into those 4 patients and look at it. And 2 of those patients were actually inpatient stroke activations. with ICH, and they had very complex medical problems that our teams actually had to communicate together with pharmacy and our ICU team of, well, should we even do reversal? Can we do it? What's the timing of this? And once we take those two patients out, our data actually shows that the time for reversal was on par to better. And so I think unless you're making this real-time judgment of the data we're collecting, you may not be capturing those avenues that can be helpful. So from a transfer process, this was really removing barriers is where we've started with this. Is number one, our neuro ICU team now accepts all ICHs. It doesn't go through neurosurgery. And we found that that is easier. Neurosurgeons can be in the OR. And so if we keep the transfer center, the neuro ICU takes them. Once the patient's here, we have a conference between neurosurgery, neuro IR, and decide, who's kind of final person for the patient, but at least they're getting here. And then really standardizing our goals and then getting that feedback to our transferring facilities. Like I said, updating our policy where we're accepting all these patients as even ghost patients if our RCU is full, and we will kind of make room similar to what we do for ischemic stroke. And then the image transfer process of always improving how fast we can get images from our transferring facilities so that we can look at this to help guide them, because some patients, they may not need transferred. It may not be something, and if we look at it, we can kind of decrease some of that unnecessary transfer stuff if we can look at the images ourselves. And so here's a list of data and metrics that overall we're kind of collecting, our current metrics that we're looking at, some additional metrics that we've added as far as our protocol compliance by each department, what are our outcomes at discharge, what are our response times, similar to what we do for ischemic stroke, and then really kind of documenting some of these barriers that we have as far as how that data is collected and the silos that we have between our departments and who's collecting it, some of the inconsistent documentation that we have. We talked earlier, the ICH score, neuro ICU, stroke neurology, the neurosurgery residents, all people can do that, but we want that to be consistently done for every patient. And so these are kind of the metrics we're doing. From the MIS specific standpoint, this is probably the easier part of the whole thing. And so initiation of when we actually start doing the operative part, we kind of had a transition where after Misty, every neurosurgery that was on call would basically take whatever came in. But now we've kind of transitioned these, at least initially, to more of our vascular team. The two of us already do IR, so we're getting the stroke calls, are taking these on. And so we've kind of optimized our institutional volume between a few of us instead of everybody at this point, until we can get enough experience with the system and everything that then we can start branching out again. We had to change our equipment. They've shown you different retractor systems and things, and so we have a different one than what was done in the trial. And so we had to go through some device reviews and approvals and get trial sets for doing this. And so that process has to be done obviously with our OR staff and hospital. And then it was important to bring the industry representatives in, depending on what your equipment needs are, of doing some model training, which all of us did a number of times before we actually went to live cases. And then obviously we prefer having case support with the industry representatives at each of our cases in case we run into issues, we have questions, kind of helping us with that. And then for these initial ones that we've done, we're doing, essentially dual operators. We have residents, we have everybody there, but the ones of us that are interested in this, we try to come to every case together at this point, which takes some scheduling and giving up some other things as far as being available, so that as a team, we are optimizing our learning with decreased number of cases to do that. And so I think that's been important from a team standpoint. So I think my conclusion, I think really as we move forward with this, and a lot of institutions may be in our boat where they were doing a lot of ICH stuff before, and until we had some positive clinical trials, now we're kind of jumping back into it. And I think it's been important to look at your entire system and how it's set up and do a real good internal review of that before you're really getting into the surgery, because from my standpoint, the surgery is kind of the easier part of all of this. It's really that pre-care and post-care for these patients that I think also needs to be optimized. And so if you're not set up for that, I mean, we can all kind of do these surgeries pretty well, I think, but unless you've got the support on the front end or back end, you may not be optimizing things for that patient. Obviously, multidisciplinary reaches into that with neurocritical care teams, EDs, transferring centers, pharmacy. There's a lot of people that are involved in this pathology that can be useful and help streamline and improve this stuff. Because as some of these trials are showing, if time is truly going to matter like it does for ischemic stroke, and the earlier you have these things done, then you really need all these systems to be working in order to get the most efficient process. And then obviously, from a data standpoint, if you're not tracking it, then you don't know how you're doing and you don't know what things to improve on or change. I think that should be everything.
Thank you so much, Dr. Peterson. I know there was a lot of really great takeaways that can be implemented locally at our attendees' hospitals. Just a couple of questions kind of combined into one. Is there always a neuro ICU bed held for ICH patients to decrease door to ICU time? And then a follow-up to that, how did you get buy-in for ICU, door to ICU in 30 minutes?
Yeah, so there historically before we started this, there wasn't, because ICH patients before, for a lot of our other trials and stuff, we had within 72 hours, right? And so we would get blood pressure control. But as part of this, we found it important that we needed that. And that's what we had on the ischemic stroke side, is like our transfer centers, ED, whatever, it didn't matter. They were going to an ICU bed. We were, a lot of times going to thrombectomy, but there was going to be an ICU bed waiting. And so we didn't have that for ICH. And I think it was just important to get buy-in from the neuro ICU team, which and the stroke neurology team who's there evaluating a lot of these patients, and it becomes an ICH. And so it really wasn't until we started this whole group together where, we had some initiative and the AHA coming in and being a part of that, that everybody kind of had a role in it. I think that was the biggest thing, is collecting the people involved and finding who was interested, and then getting those people together to come up with this plan. Once we had that, it was pretty easy to get buy-in, I think.
Great, thank you so much. I know there's additional questions in the Q&A chat, but we will address those offline and get those to you. But thank you, Dr. Peterson, for a really great presentation, and congratulations on your terrific ICH focus at your hospital.
Yeah, the rest of the team deserves all the credit. They're the ones that do the real work. I'll tell you that.
Well, thank you. As we move to our final session, if everyone wants to leave session 4 and jump over to session 5, and that can be found in the resource tab, so you can click that link and move over. Thank you.